my screen. Okay. So first, let's really quickly talk about relapse prevention. I mentioned it in a couple ways in kind of technical terms. It's called tertiary care, meaning that the individual has gone through, they've accepted that they have a substance abuse problem. They've gone through some type of detox, and then they've gone through some type of treatment program that is initially meant to kind of help them understand why they use substances in the treatment part, the therapy part, and provide skills of how to restructure why they've used and why they shouldn't, whether they're trying to completely abstain from use or if they're just trying to reduce their use. Okay, that's a treatment aspect. And then there is the medical aspect. In a lot of treatment programs, there's a medication of some type. We can think of things like methadone for opioid and methamphetamine addiction. There's three kind of medications, I believe, right now for alcohol use disorders. So usually the treatment is a combination of those things. The detox can be different for each. I will say that in that intervention component, if I think I've mentioned this in this class before, that if you do have someone who is trying to detox of alcohol, they should do it in an emergency room or an inpatient treatment center because alcoholics, when they are withdrawing from alcohol, are at the highest risk of having severe seizures that can lead to embolisms and those kinds of things. So it's a really risky time, except especially for heavy long-term drinkers when it comes to alcohol abuse. Okay. So that's the intervention. So you're detoxing them, you're giving them some type of treatment to help them understand their use and some skills to try and manage their use. And then you're doing some type of medical intervention to help them physiologically um, 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 cure from the use they're using and to help prevent further use. Okay. So we had primary prevention, and then we had that intervention model. Well, intervention model. Now we have what's called tertiary prevention. Okay. Tertiary prevention is prevention of reoccurrence of use after they've gone through some type of intervention program. And one of the main methods that is used for this type of prevention is relapse prevention. Okay. Now, there's a lot of argument in the field about relapse prevention. A lot of people, there, I'm not going to say a lot. On one side, they say a relapse is not an if, it's a when, meaning that you can almost be guaranteed, even if you've gone through the best addiction intervention program, that you will experience a relapse at some point in your recovery. Okay. And then there's people on the other end that says, well, relapse are preventable, that it's not an inevitable type of event that's going to occur. Okay. And it really comes down to how you in your professional life understand the development of substance abuse. Okay. And this is where this model right here, this table we're going to look at right now. It's called the Berksman's model of helping and coping in applied addictive behavior. Okay. And on these two continuums, on this top area here, it has, is the person responsible for changing their addictive behavior? And we have a yes or a no. And then on this one, we have, is the person responsible for the development of their addictive behavior? So is it the person's responsibility that they became an addict in the first place? And then on top of that, regardless if that's a yes or no, are they responsible for changing that addictive behavior? Okay. So these are the kind of decisions, and I'd encourage you to kind of say, where are you at as we move through these different types of models? Okay. If you believe that a person is responsible for the development of their addictive behavior and they are responsible for changing their addictive behavior, then you generally are adopting what's called the moral model. Okay. The moral model is that people who have an addiction problem do not have kind of the will or the ability to not start the addictive process, therefore they're responsible for it, and not change it, therefore they're responsible for it. So in this model, um, there needs to be some type of social control on the person in order to kind of what we would say force them to go into some type of rehab or better themselves. Okay. And an example of this is the war on drugs. Okay. Just say no is the best example of this. And relapse, okay, equals a crime or a lack of willpower. That when a person looks at someone who goes and they excessively drink again after they've been treated, that is criminal in a sense. Okay. And that it's just that they lack that ability, that willpower to change their life, but it's on them. It's because of them. Okay. The second one is, let's say no, no. So it's not their fault it's not the person's responsibility, I should say, that they develop the addictive behavior. And it's really the person's responsibility for changing it. No, it's not. It's more of a um, understanding a disease process. In this, guys, I like using the example of cancer. Okay. Now, we all know lifestyle, all that and stuff is important, but cancer is really tends to be a hereditary and a physiological event. So is a person responsible for developing cancer? Generally, no. It's some type of interaction between their environment and their genetics that then create that cancer that occurred. And because it's not because of them, and it's due to some type of physiological hereditary, the person's really not responsible for the for changing their behavior. They're just have that disease. And with that disease, we have to continue to do some type of intervention. Okay. And this is what we consider, if you believe in the disease model of addiction, okay? And that we should treat it as a chronic disease that constantly needs to be monitored and worked on. So a relapse is a reactivation of the progressive disease. So again, going back to the cancer example, a person gets treatment, their cancer goes into remission, and then all of a sudden their cancer comes out of remission and it starts up again. This is the same thing if you adopt the disease model of addiction. Relapse is just the reactivation. It's the addictive process coming out of remission and affecting the person again. Okay. Now let's look at the possibility of a person is responsible for developing their addictive behavior, but it's not something they necessarily can change. Okay. This is where we get into spiritual models, such as AA and 12 steps, where relapse is a sin or a loss of contact with a higher power. Okay, that okay, yes, you got into this addiction because you went away from your natural who you should be as a human being. And in a spiritual sense, it's losing contact with your spiritual self or your religious self. But it is up to kind of the response to the individual, putting things in there to help them connect with their higher power or whatnot that connects them. Now, we should add a few things to this to Brinkman's model, is because there is a lot of theories and philosophies that suggest this can occur on a loss of direction in one's life, not necessarily noting with spiritual models. So if we look at a lot of Native American models, for example, and some other indigenous models, and models out of Denmark and Norway and those countries, those Nordic countries, okay, they they see that someone starts to drift or starts to do things that is not in their best interest, such as getting into the addictive process of getting away from nature, getting away from who they are as a human being and losing themselves in in that way instead of it being something of a religious or a spiritual thing. It's just the person has drifted away from their nature, who they are as a human being. So that's just kind of some updates to that model from Brinkman's, is that so it can happen on a spiritual end or it can happen on a individual disconnection from who a person is in their nature, in their relationships, in their place of being. Okay. And then the last one in this model, anyways, is the person is not responsible for the development of their addictive behaviors, but yes, they are responsible for changing those addictive behaviors. Okay. And this is what we call a compensatory model. And if you've been in a lot of classes in addiction and stuff, you probably heard the term cognitive behavioral lots of times, where it is a dysfunction in a way a person thinks about their addiction, where they go through ritualized behaviors like we talked about in the first of the semester. And really, what a relapse in the compensatory model is a mistake. It's an error. It's a temporary setback. It's basically saying humans are not perfect and we make mistakes. And just because I relapse doesn't make me, for example, a bad person. It doesn't make me less spiritual. It's not because I'm necessarily giving into my disease. It's because I'm human and humans are not perfect. And holding a high level of uh, demand to not go back into those addictive behaviors are demanding. Okay. And this goes back to, and I'll just emphasize this point, the success, the success rate of addiction treatment, and even in the field of mental health, is very, very low. Um, and for a lot of providers, it becomes very, very frustrating. But that brings back to the point that the work that is required to recover from addiction and to resist relapse is very cognitively, behaviorally, and socially demanding. It takes a lot of work and a lot of energy. It's not just something you say, well, I have a craving. I'm just not going to drink. That's not how this works. And so this is kind of the compensatory model, Um, and so these are different ways you can view addiction from at least this perspective, and especially when it comes to relapse. Now, I will say, if we were to be truthful about these different models, we kind of combine them all. So we do understand there's a disease component and a cognitive behavioral component. But really, when you're looking at how to approach relapse prevention, these different ways kind of give some understanding of what we're viewing the individual as. Okay. Now, we've talked about this at the beginning of the semester, so we're not going to spend a huge amount of time on this section on the biopsychosocial factors. We went through the biopsychosocial factors at the beginning of the semester, but what I want us to just kind of re-highlight here when it comes to prevention of a relapse, prevention of going back through the addictive process, is what are these things that maintain addictive behavior? Okay. So on the biology, we can see vulnerability and genetic predispositions. Okay. We can see pharmacological impacts of excessive use of alcohol and drugs on the body chemistry. A lot of well-intending people who want to stop drinking, for example, have difficulty because of the physiological effects where they get the shakes, uncontrollable shaking in their body that can last for weeks or months. The cognitive fog that occurs. And if you ever have been around a person with addiction, they have the shakes, they have the fog, and so they do what they call a recovery drink. Okay, I had a friend who had a recovery fifth, and he says, Curtis, I promise I won't drink anymore from here on out, but I just got to get rid of all of these withdrawal symptoms. I'll just do a fifth today and then I'll sleep it off and I'll be fine tomorrow. Okay. And that really is the start of falling back into the addictive process. Okay. And then, of course, tolerance, the higher dose, the over time. And again, when we're looking at relapse prevention, a person who has been, so, for example, sober for, let's say, 2 months, they can, through their mind, go, well, you know what? I won't drink as much because my tolerance is so low. So I can go have a drink, have a good time. I and I won't drink as much. But again, that then starts the addictive process again. And we talked about the withdrawal symptoms briefly when we talked about the pharmacological impacts, but higher risk of developing certain physical diseases, okay, especially dealing with things like the liver, skin diseases, those types of things that are associated with excessive substance use. Pancreatitis is another common one. Cirrhosis of the liver is another common one. And so all of these things are part of that physiological or biological aspect. Okay. Just as a review, and I know we've gone over this before. On the psychological factors, there's a stage of habit initiation and stage of habit change. So I just want to focus on this one for a minute because we're talking about relapse prevention or tertiary prevention. Stage of habit initiation is the treatment stage. It's the detox stage. It is trying to learn how to live a sober life or live drinking less if that's the goal. Stages of habit change, on the other hand, is the relapse prevention aspects. It's actually initiating those things you learned in treatment, initiating those things that you're learning in relapse prevention, and actually putting them into behaviors and thought processes. Expectancy, this is the positive outcomes of drug use and self-efficacy. And again, when we get to dual diagnosis and we talk about that, This will be a major one that we'll talk about with those two things working together. Attributions, substance use and reason for relapse, sensation seeking, impulsivity, negative affect, and poor coping. And I'm not going to go through these again because you'll learn a lot about these in the substance abuse treatment class, because these are all the things that we work on in substance abuse treatment. And then relapse prevention takes on from there to initiate skills and thought processes to resist use. And then, of course, social, cultural factors. And again, we've talked about these, so we just can go through them again. Family history, both dysfunction in the family, but also substance use in the family, peer influence, the social pressures to engage in substance use. I always like to think of also in the peer influence, intimate partners who co-use and they feed off one another. So one might want to try and stop using, but the other develops an excuse. And of course, they can't leave them to drink alone, those kinds of things that occur. Cultural and ethnic background. Okay, so we know things like norms and religions that govern the use of alcohol and drugs, ethnic variations in body rates and efficiency in metabolizing drugs and alcohol. All of those play a role in use and substance use. It's always kind of an interesting kind of thing. So on the religious end, the Latter-day Saints, the Mormons, have a strong prohibition against alcohol use and warm drinks as well. Um, and I'm talking about this community because this community is the one that I primarily worked with in a lot of substance abuse issues. But it's interesting so believe it or not, different researchers sample our sewers to see what communities are ingesting. Okay. And it's interesting that in largely Mormon communities is where you get the highest concentration of antidepressant and anti-anxiety medications, legal drugs. And then in other communities is where you get more higher levels, but less levels of sanctioned drugs, but higher levels of non-sanctioned drugs. So just kind of, I only point this out. This is not a criticism of any religions or anything else, but I just want you to see how religious beliefs can actually play a role in the choice of the substance we use to deal with our world. Okay. Media and advertising, societal emphasis on immediate gratification and glorification of effects of alcohol and drug use, um, and the like. Whoops. Okay. And you guys, I'm going to have to end with this. I apologize. I just want to just bring up the effectiveness, though, of effective relapse prevention. Okay. And that I want to give some hope that that it is an effective thing. This is what we call untreated relapse. Okay, so a person enters a treatment program, does what they need to do to stop saying 100% want to quit and whatnot. And we have heroin, smoking, and alcohol here, and we can see, first 2 weeks pretty good, but about by the third month, only about 30 to about 45% of people have maintained their abstinence. Okay. And also untreated by 12 weeks, so at 1 year, we're down to about 40 to 20%. And if we look at one of our main substances we work with, alcohol is slightly better. But if you look right on this line for alcohol, it has the most drastic reduction within the first 2 weeks. Okay. So, reason why I want you to consider this graph is that without continued relapse prevention and relapse work, the the probability of success goes from 100% on the first day down to 25 to 35% in 1 year. Okay. And so this is a thing that I want us to kind of consider and maybe think about between now and next Thursday, because what we're going to see, I think, what we're going to see here in a little while is how the rates actually go up when we have some type of relapse prevention. So that's why we're going to go into these models a little bit more this coming Thursday. But I apologize. I got to end the class with this right here and maybe give you something to think about that there's value to thinking about tertiary care and tertiary prevention.